Rajiv is extraordinary in many ways. So he's an extraordinary cook. His knowledge of that was also quite extraordinary. I mean, he knows the back streets, back roads, all the shortcuts, just like any other cab driver. Come to think of it, he was a cab driver in Chicago. And amidst all this, he's also an extraordinary scholar. And ever since receiving his PhD at Stanford more than 15 years ago, he's done some incredibly innovative work in the area of health communication, specifically looking at risk communication, looking at how people across different cultures, societies, and countries process risk information, and also looking at how social and societal norms affect information processing, particularly behaviors. And this work has been truly, truly innovative. Rajiv is one of those rare handfuls who is not just brilliant at theory, but also methodology. And the fact that he's such an elegant writer helps a lot too. And his publication record is testimony to his scholarship. Just being published in just about every major journal in communication, public health, medical journals. It's truly fantastic. Serves on numerous editorial boards, is advisor to so many organizations, and has also been heavily funded by the NIH. But the last 7 years or so, has been doing some really important work, looking at factors affecting HIV/AIDS and how to prevent the prevalence or incidence of HIV and AIDS, and also how to reduce perceptions of stigma towards these deadly diseases in Sub-Saharan Africa. He's particularly looked at Malawi, Uganda, and Ethiopia, and this work I think is really, really important. He's going to be talking to us today about that. So welcome, Chuck.
Thank you, Sri. After this talk, you may, I won't feel bad if you take back your offer. I would love to actually, too bad I can't just talk about cooking, but we'll try to cook up something. Thank you all for coming. On a cold and rainy day, I want to know what the secret is to get people to come to seminars, because at Hopkins it's always a struggle.
Cookies.
So, I'm sorry, what?
Cookies.
Cookies, but there aren't any. So.
There are.
We also get good speakers here.
Okay. So I'm going to talk about, as you can see on the screen, some of the work that we've been doing in Malawi. I'm currently working in HIV prevention, doing HIV prevention work in Malawi, Ethiopia, and Uganda. I also did some work in Namibia, so Sub-Saharan Africa. And the environment in each of these countries is quite different from each other. And I want to say a few things about Malawi in particular. Oops. There we go. Okay. So just a little bit of background about the project itself that I'm going to be talking about. The name of the project is the Malawi Bridge Project, which was started in 2003. And basically today what I'm going to do is give you a little bit of background of the project itself, talk a little bit about some of the baseline research that we did that was very informative in giving us a better handle on what an intervention in Malawi might look like, or should look like. Then I'm going to talk about some of the trends in the outcomes that have resulted after the project has been on the ground for now 6 years, and give you two specific examples. We'll talk about two specific examples, what we call targeted interventions. So the Bridge Project is this very large, as you will soon see, very large project that's being conducted nationally. And within that large framework, there are smaller targeted interventions that are, frankly, much more fun to do. And I'll talk about that as well. And two of those are, one is the Radio Diaries program that has won a number of international awards in reducing stigma. And the second one is a much smaller school-based intervention focusing on 10 to 14-year-old So in terms of the background, in 2003, the Johns Hopkins University Center for Communication Programs, part of I'm affiliated with that center, received a grant from USAID, which is the United States Agency for International Development, to do a behavior change HIV prevention program in Malawi. And that's when we started the Malawi Bridge project. So that's about 6 years ago. The project was initially a 3-year project that then got extended and kept getting extended, and it finally ended in 2009, early in the summer. In late 2008, the USAID office felt that they had to put out a bid and ask for other people to apply. And so we put in a bid and were re-awarded another 5-year extension. So now the Bridge 2 is what we're calling it, is going to be running till 2004. So that's very briefly the background. For those of you who may not know about Malawi, that's where it is. Small country, landlocked country in southern Africa. It borders Tanzania, Mozambique, and Mozambique actually comes around. It's not a very tourist-oriented place, although there is a lot of traffic, especially people from South Africa going to other parts of Africa, pass through Malawi. And there's this that blue long thing is a lake, Lake Malawi, that is actually quite beautiful. By most accounts, HIV in Malawi is a very serious problem. It has been for a number of years. Not only is the country very, very poor, it also has, if you just look at some of those numbers, roughly 12% prevalence. That's on the average. The northern part of Malawi tends to be much wealthier, relatively speaking. Southern part is where the big problem is, and in the southern part of Malawi, the prevalence can be as high as 20–22%. So what that means, and it sort of was brought home to me one day, was if you're giving a talk, if you're giving a little seminar or something, and there are 100 people there, chances are 22 people are HIV positive in the south. So, and there are, as you can see, 70,000 HIV positive children. And in a country of 13 million, there are 3/4 of a million orphans. Just to give you a sense of the factors that people are dealing with. When we did our formative evaluation in 2003, a number of things emerged, and we've sort of done presentations of this elsewhere. I'm not going to go into a lot of detail about that. I can give you citations if you want. But basically what we found was there was very little in the sense of what we would call perceived control. In other words, there was a lot of helplessness that was just part of the norm in terms of poverty, which was very, which continues to be a very big problem. And so, if you're dealing with where's my food going to come from tomorrow, HIV just seems like a very, very distant problem. Also, a lot of inability to talk about sex and sexuality, given the cultural norms. However, there was, we found, a tremendous desire. People were actually quite hungry for information and for good, solid information about HIV, which is always a good thing. There were also, at the time, almost complete absence of any large-scale prevention efforts that were going on. And in that climate, there was also a pretty high level of stigma towards people living with HIV. So having HIV was considered a death threat almost. And so people were very reluctant to talk about HIV in their homes and their communities. So a very difficult environment to work in, at least at that time. And I think I also want to say before I leave you with this very grim picture that Malawi is also one of the warmest countries that you will ever find in terms of people's personalities. I've worked in at least half a dozen countries, and Malawi is my all-time favorite go to these homes that, by way of possession, maybe have 2 cooking pots and a mat and a wooden cot. They are the most hospitable people that I have encountered anywhere. So I find it really a privilege to work in that environment. It's a very easy environment to work in that regard. People are very open, very inviting, inviting to your homes. At any rate, the implications of our findings from the formative evaluation was that we really felt that we needed to focus on enhancing the sense of control and efficacy if we were going to bring about any change. And so that's what we focused on. And the second implication was that if we are going to promote HIV prevention, that means promoting HIV testing, because there are one of the big sources of HIV in Malawi is what people call discordant couples. That's where one person is HIV positive, the husband usually, and no, I shouldn't say usually. So one person is HIV positive, the other one is not. Before I move on, I want to stop and ask you a question. If one person is HIV positive and one person is HIV negative, forget that it's a spousal relationship in just a second, right? How many times do you think you need to have sex, unprotected sex, with someone who's HIV positive before you become HIV positive? So in other words, what are the odds, if you're HIV negative and you sleep with someone who's HIV positive and not wear a condom, what are the odds that you would become HIV positive? So I'm going to give you 3 ranges. I want to see a show of hands, all right? So the 3 ranges are going to be, the odds are that you would become HIV positive, 1 in 5, 1 in 500, or 1 in 1,000, right? So how many of you think it's 1 in 5? How many of you think it's 1 in 50? Or 1 in 500? What were the odds again?
You know the answer.
I know the answer. And okay, so the answer is actually it's 1 in close to 1,000.
Really?
There are lots of other differences. There are lots of differences, but on the whole, if you look at just sheer probability, those are the odds. But that's not what you would think, right? If you listen to public health announcements, public service announcements about HIV. Now, there are other factors that moderate that relationship, obviously, right? So, depending on viral load, for example. So, initially, when you get HIV, your viral load is very high. That's when you're actually very, very infectious. But unfortunately, that's also the time when most symptoms really appear. So, you see the problem. Anyway. So we, in order to promote HIV testing, which, as you can imagine, is a very necessary first condition, we need to get people to talk about HIV. And if there's an environment in which there's a lot of stigma, that's not going to happen. So tackling this issue of stigma was very important to us. So the approach that we adopted was sort of unfolded in 3 phases. In the first phase, we really focused on promoting self-efficacy. And I am a big fan of social cognitive theory. Many of you sure know about it. I don't need to go into it. But there is really nothing more powerful, I believe, and I think there's a lot of literature to support it, in promoting behavior change than enhancing people's efficacy. In fact, if you look at the literature, the best predictor of behavior change, the best predictor of behavior, apart from prior behavior, is really self-efficacy. And so we sort of latched on to this idea from the very beginning, and the approach that we adopted was what we sort of came to call doable steps. So it's not, let me enhance your efficacy to protect yourself from HIV, who the heck knows what that means, right? But let me enhance your efficacy to buy a condom, keep a condom with you, to talk about condom use with your partner, to bring up the issue, things that are much more proximal, much more doable. And then in the second phase, it became very clear to us that given the power differences between men and women in the society, that men had to be brought into the fold, men had to be And then in the third phase, so that people don't slack off, we continue to focus on enhancing perceptions of risk. So from a theoretical perspective, informed very much by social cognitive theory, the approach, the one particular strategy we adopted was the risk perception attitude framework, which is, and I'll talk about that in just a second. Basically, it is an audience segmentation device in which you categorize people according to the psychosocial profile, in this case, perceptions of risk and perceptions of efficacy, and then you design messages accordingly. Okay? If you think of a simple 2x2, where you've got perceptions of efficacy or disease prevention efficacy across the top in the two columns, and then your perceptions of risk across the two rows, then you get you can put people into one of these four cells, right? So if your perception, if you think, it's not going to happen to me and there's nothing I can do about it anyway, right? No problem, no solution. We would classify you as being indifferent. If, on the other hand, you think that your perceptions of, I don't think I'm really going to get heart disease, but even if I were, I think if I were to become more susceptible, there are lots of things I could do. I could stop smoking, I could curtail my drinking, I could start eating more vegetables and so on. So if you feel efficacious in doing that, we would classify you as being proactive. If you think that you are at tremendous risk and, oh my gosh, there's really nothing I can do about it, and I'm just going to bury my head in the sand and pretend nothing's going to happen to me, we would classify you as being in the avoidance group. And then where we would want everybody to be, especially if you're living in a country in which there's 12% HIV prevalence, we would want you to believe that, yes, you are susceptible to HIV, but at the same time, there are lots of things that you can do to protect yourself. In that case, we would classify you as being responsive. So we would push people towards that cell. And so the prediction, once we classify you in one of these four groups, the prediction is that the healthiest behaviors will be displayed by people in the responsive group, right? That's the high risk, high efficacy group. The least healthy response is going to happen in the indifference group. That's the low risk, low efficacy group. And then the other two groups, the avoidance group and the proactive group, are going to be somewhere in the middle. When we test that, the predictions of that out, and this is data that were published in the Health Communication Journal last year, what we see is, now this is for people's monogamy-related behavior. That is, are you going to stay abstinent if you're not in a relationship? Okay? And when we look at that as the outcome, now the blue line here pertains to people who have weak efficacy. And here what you see is that there's not a very strong relationship between your perceptions of risk and your monogamy-related behaviors.
So is that supposed to be remain, what's the word, abstinent, if not in a relationship? Okay, because if you're not in a relationship, you can't be monogamous, right?
That's right. Oh, and to have only one partner if you are in a relationship.
Okay.
Yes, thank you. Yes. And then when you look at people with high efficacy, what you see is that perceptions of risk. So for this is the responsive group. This is the group that has high efficacy and high perceptions of risk, and they show, in fact, the healthiest behaviors. Right? So what? Oh, by the way, and I should also say that what is also very clear here is that the primary motivator of action, right, which is the red line, is efficacy. The red line is clearly above the blue line. So if you had resources to put only in one basket, it should be the efficacy basket. That's clearly sort of what is being demonstrated here. You're getting a very strong main effect of efficacy, and then there's one interaction with risk, but that is much smaller compared to the main effect of efficacy. So Indita slogan. Indita in Chichewa means I can. And just for the record, this was 2004. 4 years before our president came on the scene. The entire intervention was built around Indita, around the self-efficacy testing. So just in terms of the description of the campaign itself, it was a pretty massive campaign. It sort of unfolded after extensions that we kept getting. It was actually designed for 3 years, the campaign was, and then it sort of went on to become a 9-year campaign, or a 6-year campaign, I'm sorry. And so many of these things unfolded without us having the luxury of knowing how long we were going to be in town for. I sort of want you to be aware of that. So there were lots of mass media things that we did. One of the things, I'll just highlight a couple of things in this list. This thing became immensely popular, the scratch cards. And scratch cards are this, it's a little card with items around knowledge. So this is like a knowledge quiz, right? So HIV, so this particular drug is used for, and then there are 4 answer choices, and then you scratch off to see whether you got it right or wrong. Initially, we printed 5,000 and quickly realized that we were short and had to print lots more. Then there was a very strong community mobilization effort in which we worked with, instead of trying to impose our own structures, we worked with existing structures. And in this case, they are what they call the village AIDS committees, the community AIDS committees, district and national AIDS committee. We work with youth groups, women's groups, faith-based organizations. Malawi is roughly 85% Catholic and 15% Muslim. So we work with Catholic priests and imams. There were a number of very targeted interventions, one of which I'll talk about today, which is this radio program for girls. And then I'll also talk about the Radio Diaries program a little later. The research design, so all that's the program side. On the research side, so we did baseline research in 2003, right before the campaign started, which is what I've been talking about so far. That had both a qualitative component as well as a quantitative component. And then we've been doing household surveys, midterm in 2006, 2.5 years into the campaign, another one in 2007, and then an end of project outcome evaluation was done in 2008 and disseminated in about this past summer in July. Okay. In most of these, basically what we do is we use TAs. In Malawi, TAs are what they call traditional authorities. TAs are sort of equivalent of that here would be a county. So you've got a district, which is sort of like a state here. And then below the district is a TA, which is like a county. And that's where we did the sampling. Households were chosen at random. 1 person per household was then chosen at random within that. Roughly 1/3 were youth, equal males and females in the study. And then the midterm 1 and midterm 2, so that's the baseline. And then for midterm 1 and midterm 2, it was the same design, except we took, we divided each district into areas where we were working, so these are the high intervention areas, and then areas where we were not working, low intervention areas. Now, mind you, there's a very strong mass media component, so you don't really have a true control group because media is national. And you can't randomize people to say, you are in the condition where you can't listen to a radio, right? Instead what we did was we took these high and low exposure areas and then randomly selected people from within those. Okay. The survey instruments that we've used are ones that are first, we take our existing measures from other countries in Africa in English and then translate that into the local language and then back translate it, follow very standard procedures, compare the original versions and then make sure that they're equivalent. And for most constructs, we've not had much problem time getting people to understand, first probability, right? Because if you're talking about what are my chances of getting HIV, and we've tried all kinds of things, and I'm still not 100% convinced that we've got a very sound measure for Malawi. Nevertheless, yes?
Rajiv, have you looked at anything in terms of how numeracy affects these responses, the numeracy literacy issue?
Absolutely. And one of our graduate students did a very nice master's thesis on that. And so, as a result of which, we've stayed away from anything that has to do with numbers, because the literacy level is very low. And so when we ask about perceptions of risk, we don't use anything to do with numbers. So we say, for example, even when we administer a Likert scale that has, say, from 1 to 5, right, very strongly disagree to strongly, even that is a very difficult concept to measure. So what we do is we say, do you think you can do this? So if you're asking, say, for self-efficacy, do you think that you can wear a condom the next time you have sex? And if they say yes, then we say, well, do you think you can do it all of the time, or most of the time, or not at all? And so each question takes about 3 iterations before we really sort of. So that also limits the total number of questions we can ask. And we've tried all kinds of things, with pictures of grains to show magnitude, but then they get stuck on, oh, you mean rice or wheat? It's challenging, and there is, I think, especially if people are interested in methods, there's a lot of work that could be done. I think that's really, really interesting. Yes?
So I have a follow-up question.
Yes.
So when you're talking about risk perception, and you mentioned that they have this difficulty in perceiving risk, could one of the factors be the fact that there is a big disconnect between their actual perceived knowledge? So if their actual knowledge is well below their perceived knowledge, then they'll be finding it difficult to actually estimate their risk perception. So there is something that could be done in order to bring their actual knowledge to the level of the perceived knowledge such that they're both equal or the same. Then they'll be in a better position to actually report their risk perception. And then, of course, you would have an interaction with self-efficacy then, but that's another thing altogether.
I think the issue with, that may well be true. I think the first thought that sort of comes to me in response to that is telling a survey interviewer anything to do with your perception is perceived as a luxury. What I mean by that is when your day-to-day life is very, very difficult, you often do not have the luxury of contemplation to figure out, to sort of evaluate how difficult your life is. Otherwise, you'd be very hamstrung, I think. You couldn't get anything done. So, when you've got a 14-year-old girl who's carrying a huge pail of water on her head from, the bottom of the hill all the way to the top of the hill every day, I don't think she has the luxury to reflect on how difficult that is. Because then she would, so I think whenever we're talking about perceptions, if I ask you, do you think that, how knowledgeable do you think you are about HIV? I think that's in many ways, it's a very Western biased question. Because you're asking people to reflect on their perceptions. And so what we have found is that our surveys, which may take 35, 40 minutes long, in reality end up taking much longer because people don't want to let us go.
I think you need to have a 3-condition experiment within that survey to actually test that.
Okay. Okay.
Do you have a position for him at Johns Hopkins?
You'd be always welcome. Okay. So the data collection, I just want to acknowledge the 2 local consulting firms that we've worked with very closely, who collect most of our data for us, do a fantastic job. Without them, we wouldn't be able to do our work at all. The Sub-Saharan Consulting and JNF Solutions. Okay. So I want to just very quickly show you some, so did your tax paid dollars make any difference. We hope they did. So just some numbers to show you what kinds of effects we've been having. First, let me show you some numbers around exposure, right? Because we know that if you don't have exposure, nothing else is going to work. So when we've done assessments of our exposures to various programs, what we've found is that the Endita slogan, which is the sort of tagline that we have used, is recognized by close to 90% of the people. The posters, you can see there, that, it varies widely between posters, that's about 47%, to the youth alert mix. This is a youth-oriented radio program that's broadcast on weekends, following the entertainment education kind of format, lots of rock songs and so on, and within that are embedded HIV prevention messages. So that's getting, even adults are listening to that, otherwise that number wouldn't be that high. And then this radio program that I'll talk about is also fairly high, even though that's targeted specifically for young girls. See, that's what I mean. When you put good information out there, you think it's good. There's a tremendous amount of appetite for information like that. So people are actually tuning in. Now, it's also the case that we're not working in a media-saturated environment. When we started, there were 3 radio stations. Television, by the way, is only in the 2 big cities. It's non-existent. Radio listenership is close to 100%. So there were 3 major radio stations. Now there are about 12. So that's also rapidly expanding. So it's getting, the media environment is getting more cluttered. But nevertheless, you're seeing, these kinds of numbers in the States, wow, we would jump up and down with joy. Okay, knowledge about AIDS. So did we make an impact? So we asked, just to give you a sense of the kinds of questions we asked, it's a true-false, multiple choice kinds of questions. Knowledge battery, in which we say HIV and AIDS are the same thing, true or false. A person can get AIDS from mosquitoes. It's possible for a healthy-looking person to be HIV positive. Mother can transmit HIV through her breast milk, and so forth. Each correct answer is rewarded as 1 point, incorrect is 0. So here's what we have seen over the years. So from at baseline, the average score was 71.8%. If you convert that to 100. So if you get 100%, you answered every question correctly. So basically C, right? And from baseline to the first midterm, that number jumped up significantly, and then it sort of hovered around that same number. So when the intervention was there, now I should say I don't want to take complete credit for that. Clearly there are other things and secular trends happening, and I'll talk about that in just a second. But after that, it's sort of stabilized. And you'll see this trend in a lot of other outcomes as well. Measures of efficacy, so we ask people about their confidence in their ability to remain faithful if in a relationship, to remain abstinent if not in a relationship, use condoms during sex, talk to a partner about condom use, and reduce number of sexual partners. It's a 5-point scale that I was just explaining a minute ago. And here what we have found is that same pattern from baseline to, so this is efficacy to be faithful. On a scale of 1 to 5, 3.8, and then that jumps to close to saturation, 4.9, and then it sort of stayed there from there on. The same pattern in abstinence, and this is, I don't know what the heck is going on, to be completely honest. We've looked at the numbers this way and that. I asked my graduate students to go back and recode that. It wasn't her fault. The only thing we can think about is that there were, in 2 of the districts, there were PSI, those of you who are familiar with the international work, Population Services International, which is another big player in this work. They were doing a lot of condom promotion, but I don't know that we can directly relate that to the drop. But what was good for us was still from baseline to in the project, that number sort of went back up again to 4.7. Efficacy to use condoms, same pattern. So there's a smaller difference now, but there was a big jump from baseline. And then your efficacy to talk to your partner about condom use, exactly the same pattern. And the same thing with your efficacy to reduce the number of sexual partners. So over time, the trend is very positive.
Did you do anything with gender in that? That's everyone?
That's everyone. There are other yes, we have looked at young, we typically look at girls, boys, men, women, 4 groups. Overall trends are not that different, although there are some sort of, things jump up and down. Stigma, we used 3 measures of stigma for this particular, for the analysis that was done throughout. One is the belief that people with HIV should be isolated from the rest of the people. So we asked people 3 or 4 questions about that. How strongly do you believe that? People with HIV should be avoided at all costs. And HIV positive teachers should not be allowed to teach in schools. HIV positive vegetable vendors should not be allowed to sell vegetables, etc. And what we have seen there is, again, the same pattern, right? So from baseline to the first midterm, so this is percent people who agree with those statements. So higher the number, greater the stigma. About a quarter of the people agreed with this belief that people with HIV should be isolated, and that has dropped significantly. People with HIV should be avoided, and that is also, we see same patterns. And HIV positive teachers should be banned from teaching in schools. That belief was, a third of the people roughly believed that in the beginning, and that's still, that 9% is still pretty high, but that has dropped down. Risk perception, so this is belief that one is vulnerable to a disease or a condition. In this case, we measure risk in terms of how likely do you think it's going to happen? I'm not really sure it could happen, or it's definitely going to happen. So it's a frequent scale. In the next 6 months and the next year. And here what we find is, so people who think that HIV could happen to them in the next 6 months, we started with 11% and have now come up to 47, 48%. But as I was saying earlier, I sort of take this with a grain of salt because I'm not fully convinced that we are truly measuring perceptions of risk. In the next year, you see the same pattern. We've asked this question also in your lifetime and in the next 10 years. So when in the absence of information, which is, I think, the scenario that was prevalent before 2003, when something comes on the scene, people gain knowledge rapidly, and then it's hard to bring about change beyond that. We also ask questions about intentions to engage in various behaviors, so likelihood of taking action in the near future in terms of being faithful to your partner, remaining abstinent if not in a relationship, using condoms, and so on. And here we see this is for intention to be faithful to your partner. 79% said yes. That has gone up to about 95%. To be abstinent if not in a relationship, the beginning to end numbers are significantly different, but that number has come down somewhat from the high of 95%. And condom use, intention to use condom the next time that you have sex, and that is the difference is smaller there than the others. HIV testing is another behavior that has been promoted quite heavily by the campaign, and we see pretty strong differences here as well. And this is at baseline, the 21% of the people had been tested for HIV, and this is, by the way, ever tested. And that went up slightly, and then now it's 54%. That number is, this trend, I should say, is prevalent throughout Sub-Saharan Africa, not just in Malawi. And a big part of that is the so the tests have gotten much more sophisticated. You can get your, there are rapid tests now. The stigma is much lower about HIV testing, but most of all, medication that's a very positive outcome that we have seen in the last few years. Okay. So all these are just trends, right? Did our project, did the campaign make any impact? Can you attribute, how much of that can you attribute to the campaign itself? So in a multivariate analysis in which we first control for demographic factors like gender, age, your marital status, and education. Gender does not, now this is for knowledge, so how knowledgeable are you about HIV? Males and females, equally knowledgeable. Age does not matter, marital status does not matter, education, not surprising, right? Education is a huge predictor of knowledge. Exposure to other, so we tried to control for as much as we could, so we asked questions about, so we showed them all the different logos and print brochures and so on, and billboards, and we had pictures of billboards that were produced not only by us, but by the Ministry of Health, by other partners, and others that were working locally within each district. So in each district, there might be CRS, for example, Catholic Relief Services. They do a lot of work with treatment. So we would show them their campaign materials and say, have you seen this, have you seen that, and so on. So we tried to control for as much as we possibly could. And there, so when you see non-bridge, so these are not our campaigns, they're actually, the relationship is negative. We didn't share that with them.
No, that's sad though.
And I think much of that is because our knowledge item focuses mostly on prevention and transmission. And much of the work, there's very little prevention work being done. Much of the work is being done around providing medication. So it could be that people who are getting medications think, oh, it's not, I don't need to know a whole lot. I've gotten medicines, I'm okay. Exposure to national level campaigns. So this is the one undertaken mostly by the Ministry of Health. That shows a positive effect. And then when you control for all of that, bridge exposure to our campaign is still showing not, I wouldn't want to write home to my mom about it because the influence is kind of small. Nevertheless, statistically significant. Community vibrancy. So as you saw in the earlier slide, there were mobilizing the community is a big part of our intervention. So we assessed that as well, which is what we call an index of community vibrancy. And this is, how vibrant is your community with regard to HIV work? We've done factor analysis and other psychometric work on this index and come up with 3 dimensions. And the 3 dimensions are the level of activity that's happening in your community, how much organizing there is in your community, and how much unity there is in the community to fight HIV and AIDS. And when we look at these dimensions, basically what we see is, when you control for all the demographics and all the other things that I showed you, exposure to bridge was associated significantly with each of these. So in other words, there is something happening in these communities where we're very active that makes people think that, yeah, our community is getting together, organizing, and being active in the fight against HIV. Moving on to stigma, that was another outcome that we focused on. So when we looked at, when we controlled for other factors, exposure to bridge, so your tendency to avoid people with HIV, we see a nice effect. Fear of casual contact is a variable that USAID has introduced in the last 3 or 4 years. That's why it was not in the previous slides, because we didn't actually measure it before. And this is data with end of project, so it is a relatively new variable for us. And this is, how fearful are you of sharing a minibus ride with someone who's HIV positive? Things like that. So here too we see nice effects. Tendency to blame people with HIV. It's their fault, they brought it about, we shouldn't have to worry about it. We didn't see any effects in terms of exposure. It was 0, was the beta coefficient. And then they should be ashamed of themselves. That's yet another dimension of stigma. There we see significant relationship.
Is there, did you see by any chance any difference in, I guess, the concept of like blame and shame for kids maybe who inherited the HIV versus people who contracted it?
We haven't teased it apart in that way, but I can certainly see where you're going with that. I mean, there is a pretty good body of work that says that perceptions of controllability and your sort of the extent to which you're responsible for bringing this about is pretty strongly correlated with that, right? So I think if we looked at it that way, we'd probably find the same effects as well. I wouldn't be surprised. Yeah. Then here it is this risk perception. We saw trends in upward trends in risk perception, but we saw no associations with our campaign. And I don't know whether that's a measurement issue or we didn't make an impact. Yes.
Another question: when you're measuring risk, if it looked like the campaign was increasing people's intentions to perform positive behaviors, when you ask them about their risk perceptions, if they're more likely now to use condoms than they were before, they actually think they're at lower risk because they're doing good behaviors. I mean,
that is precisely the question that we struggled with when we wrote the application for Bridge Phase 2 and ended up with, so our solution, so you're absolutely right. Yeah, I mean, I'm with you 100% on that. Cross-sectionally, it's impossible for us to tease that apart, right? So for Bridge 2, the new innovative thing, which you'll see in a minute, is we have a longitudinal design. USAID fought tooth and nail. They didn't want it because they perceived that to be much more expensive, which it is, because you're going to have to follow the same people over time. And now, with so much mobility, it's hard to keep track of people. And so they were concerned that we would end up with data that was not generalizable because you'd have a huge attrition in the sample. But if you invite me back 5 years later, I'll show you data on that, because I am with you 100%. And the reason why, sort of just anecdotally, what we have found is that when you go to HIV clinics, testing clinics, and we've done studies in which we've asked people about their prior sexual behaviors, and then we ask them about their then they get the test result, and then we ask them about their future intentions. So will you wear a condom? How many sexual partners will you have, etc. What we find is fascinating, that people who have led a pretty risky life in terms of having multiple partners and not using condoms, when they get a negative test result, their behaviors, their intentions are horrific. Because it's almost like, oh, I've now gotten license, that I'm somehow not, I'm immune or something. So it's a real problem. And so that has implications for how you counsel people in these clinics, which there's not a whole lot of. But you're absolutely right. And that could, hopefully that's what's masking this null findings. Thank you for that. Okay. And then in terms of self-efficacy, so we see effects of self-efficacy in this variable pretty strongly, which is to talk openly about HIV with your partner, with your kids, with your family members. And this was sort of our attempt to bring in a sense of openness about being able to talk about these issues. And then for abstinence, we see pretty strong self-efficacy effects. For faithfulness and condom use, significant, but again, pretty small. For behavioral intentions, condom use, small, abstinence, small. So all these are relatively small, but again, for talking openly about HIV, we see a much larger effect. And then this is for HIV testing. So did exposure to Bridge, was that associated with testing?